impingement or valgus overload. Electron process essentially impinges on the electron process pad, which is located back here. These are the same areas that we were talking about before, which can show up on an x-ray when there's an effusion in the joint. They get pushed out. So you can see the synovial lining going around with synovial fluid here. When you increase the synovial fluid, that'll typically push the fat pad out. This is not something you see in this condition, however, it just gives you an explanation of why you might see a sail sign on x-ray. With posterior impingement or valgus overload, typically what ends up happening is the terminal extension, which continues to irritate that posterior fat pad. It's common in throwing athletes and associated with cubital tunnel syndrome in approximately 25% of patients. The mechanism of injury, once again, is that repetitive snapping or rapid full extension of the elbow repetitively. Other chest exercises can do it, so chest press dips for tricep snaps and press ups, as well as throwing. And it's associated with ulnar collateral laxity or insufficiency. Differential diagnosis includes electron bursitis, posterolateral instability, osteoarthritis, osteochondritis discans, osteochondral defects, electron stress fractures, snapping tricep syndromes, and ulnar nerve subluxations. On examinations, they will typically be painful at the posterior aspect of the electron fossa with elbow extension, so that terminal extension will cause quite a bit of discomfort. They may or may not have an effusion in the joint, and they may have some valgus laxity, and the posterior medial electron may be tender. Imaging, typically look at X-rays, CT, and MRI as options to better visualize for osteophytes, as well as edema in the posterior fat pad. In terms of management, conservatively, we look at modification of the activity, trying to reduce that terminal extension and extension snapping the elbow. Surgically, if conservative management fails, you can consider resection of the electron process, osteophytes, or debridement of within the posterior joint. Elbow osteoarthritis. So this is essentially loss of joint space, osteoporosis, subchondral cyst, and osteoporosis involving the elbow. Can be idiopathic in secondary trauma or prolonged immobilization, and it's associated with pain and crepitus. This is one of the things we talked about that sometimes you'll see even in the absence of any kind of significant osteoporosis or some subchondral cyst formation in patients that have been immobilized for long periods of time. They will have a loss of range of motion in their elbow. So it's something to keep in mind when you're recommending immobilization, to be careful with it. In terms of mechanisms of injury, which we just talked about, these can often come on without any specific trauma when the pain sets in. It can just come on out of the blue, or sometimes with increased activity. The differential diagnosis includes lateral tendonitis, radial head fracture, radial tunnel syndromes, lateral elbow osteoarthritis, extensor tendon strain tears, and supinator strain tears. On examination, there's typically a loss of range of motion with or without an effusion, and there's pain over the radiocapitellar joint line posteriorly. Obviously, imaging and X-ray would be ideal for these, so that you can view the various osteoarthritic changes. In terms of management, you can consider physiotherapy to maintain the range of motion, an elbow sleeve, anti-inflammatories, cortisone injections, arthroscopy if there is essentially an isolated osteophyte causing either anterior or posterior impingement, and eventually in cases that fail conservative treatment, you could consider arthroplasty. Fractures of the elbow. So this bit is kind of just a general introduction into the 4 common fractures of the elbow. Supracondylar are the commonest elbow fracture in kids, and mechanism of injury is typically an axial load and fall into the arm forend. On examiners, they're tender in their distal arm. There's typically an effusion in the elbow. There's a loss of range of motion, and keep in mind it's very common for there to be a neurovascular disruption in these kids. Imaging, they'll have a sail sign. That's where we talked about that anterior humeral line transecting the midline of the capitellum here. The management obviously should involve initially some immobilization reduction if it's displaced. An orthopedic consult is up to 10% will have a nerve injury and 0.5% will have a vascular injury. Radial head fractures, These can cause mid-distal forearm pain. So even though the fractures typically, for example, this one here, which is intra-articular, typically in the proximal location, they'll typically describe pain in the mid to the distal forearm with rotation of the forearm. Once again, it's usually caused due to an axial force on the forearm. It can be shown on an X-ray. The management is typically with a sling as needed, so that they can take it out of the sling when they want to rest the arm. And if it's intra-articular and there's some displacement or significant combination, recommend an orthopedic consult. The Electron is the most common elbow fracture in adults. It's typically due to direct impact or a triceps avulsion. See the triceps avulsion slide. Examination of the tender, there's an effusion in the joint, and there's a loss of extension. Imaging, once again, X-ray is very good at viewing these, as well as a CT scan to characterize for surgical planning. And management for an Electron fracture would be an orthopedic consult for potential open reduction and internal fixation. And finally, a medial epicondyle, either avulsion or traction fracture. So typically this is either a single valgus force or can happen in terms of a traction apophysitis with repetitive microtrauma or repetitive throwing. And it can also happen with a subluxation or dislocation of the elbow. On examination, if it's acute, it's typically have the bruising, there'll be tender, and there'll be limited range of motion. Imaging, X-ray or MRI would be most helpful. Management is typically with immobilization. If there's any form of displacement, typically we would recommend an orthopedic referral for these and consideration for open reduction and internal fixation of medial epicondyle. Synovial fold or plica syndrome. So people more common with the plica syndrome affecting the knee. There's also accessory plica folds that can affect the elbow. Synovium fold has these remnants that essentially encroach into the joint on the elbow. It's somewhat like a meniscus, as the lateral fold can extend circumferentially around the radial head in that radiocapitellar space. Patients are typically asymptomatic with the plica, and in fact, there's been cadaveric studies to show that they're present in over 80% of cadavers. However, when patients have a traumatic event, such as a direct blow to the elbow or any kind of microtrauma or repetitive flexion extension injury, what they'll typically refer to as their symptoms are painful snapping, locking, and or lateral elbow pain. And the differential diagnosis is quite broad. Obviously includes osteochondral defect, osteoarthritis, subluxing ulnar nerve, snapping triceps, lateral epicondylis, and radial tunnel syndrome. And on examination, they're tender over the lateral and posterolateral elbow, specifically for the ones that are where it's the posterolateral plica that's affecting them. Imaging ultrasound can often identify the issues as it's quite superficial, but you can also consider an MRI, which would be good for reviewing the plica. Management initially, as these are typically due to direct trauma, is to consideration for rest, protection of the elbow, considering bracing, and then a gradual progression of the range of motion. If they persist or continue to recur, they require arthroscopy and consideration for excision of the plica. Ulnar nerve subluxation. So this is a snapping condition of the medial elbow that involves the ulnar nerve popping in and out of its humeral groove posteriorly. This is essentially right posterior to the medial epicondyle here. So there's a bit of essentially a groove here. Some patients will have a shallower groove than others, which may predispose them to this happening. It may occur secondary also to disuse muscle atrophy. So somebody who used to do a lot of weight resistance exercises and then stopped, or like I said, it's shallow to secondary to those shallow posterior grooves. The differential diagnosis can be difficult to distinguish between this and the snapping tricep syndrome, as mentioned in that lecture slide. Cubital tunnel syndrome, or compression of the ulnar nerve at various positions around the medial elbow, and plica syndrome. The ulnar nerve subluxes out of the groove and over the medial epicondyle, which typically occurs around 70 to 90 degrees of flexion, there's usually a positive Tenels, and weakness or paresthesias can occur in the fourth and fifth digit. And this may include weakness in grip strength. Imaging at dynamic ultrasound is usually helpful in these situations. An MRI may show that the ulnar nerve is displaced medially. Management, conservatively, you can consider taping and restarting weight resistance training if secondary disuse atrophy. If it persists and continue to bother the patient, especially with the neurological symptoms, which can be quite distressing for the patient, consider referral for surgical fixation or transposition of that ulnar nerve. Ulnar nerve injuries, so a contusion or impingement, also known as cubital tunnel syndrome, or compression of the ulnar nerve secondary to direct contact or indirect through swelling of adjacent tissue. So the mechanism of injury, like once again, there's several mechanisms of injuries for ulnar nerve injury. So once again, you have a direct impact. It can be associated with subluxations or dislocations or fractures of the elbow. So secondary swelling that's impinging on the nerve. Impingement can also occur secondary to osteoporosis or to essentially movement of the nerve during arthroscopy or surgery. It can happen due to an overstretching, or, for example, if the elbow's in flexion for just a prolonged period of time. And finally, if the ulnar nerve itself is subluxing. The differential diagnosis includes an ulnar collateral ligament injury, supracondylar fracture, Galen canal syndrome, cervical radiculopathy, brachial plexus injury, ulnar nerve subluxation, pressure palsy, thoracic outlet syndrome. So on examination, they're typically tender over the ulnar nerve at the posterior ulnar aspect of the elbow. There's a positive Tenels at the ulnar nerve at the posterior elbow, loss of ulnar distribution and the sensation of digits 4 and 5, and it's typically worse with elbow flexion and or motor weakness of the hand. Imaging, EMG and nerve conduction studies can be helpful with dynamic ultrasound, X-ray to rule out any kind of associated fracture or osteoarthritis or osteophytes which may be impinging on the nerve. Management, depending on the cause, but if there's direct contusion, icing, reducing the amount of elbow flexion and avoiding repetitive triceps contractions can be helpful. Protecting from leaning on the medial posterior elbow. And then if it's secondary to fracture or subluxation or dislocation, obviously reduce the injury and then protect the elbow. And then from a surgical management perspective, considerations for decompression or anterior transposition of the ulnar nerve and potentially a medial epicondylectomy. We had a little spin there just because it's a bit of a longer slide. Stress fracture, so these are overall quite rare. If they're overall quite rare, Electron would be the commonest of the rarest. There's a high association of either ulnar collateral ligament and or medial epicondylar avulsion fractures in well over 70% of the cases. And in terms of radial stress fractures, it's based truly and only on case reports. Both are typically due to overthrowing. Differential diagnosis includes Electron, bursitis, lateral epicondylitis, valgus overload, osteoporosis dissecans, radial tunnel syndrome, and osteoarthritis. On examination, the Electron demonstrates tenderness, palpation of the posterior medial elbow. With respect to the radial stress fractures, it's typically from overuse of the supinator, so the supinator will be tender, can be inflamed, as well as the insertion onto the radius, so the proximal third of the radius. In terms of imaging, X-ray sometimes can demonstrate it, but often MRI, CT, or bone scan would be required to demonstrate the stress fracture. There have been some cases in the literature which have been determined by ultrasound detecting a cortical irregularity in the area. In terms of management, you obviously want to protect and rest either the Electron or radius, or specifically the elbow, from the aggravating activities, which is mainly throwing. If there's recurrent or instability, consider obviously a surgical referral for those associated injuries, example, ulnar collateral ligament or medial epicondylar avulsion fracture. Electron bursitis is very common. It's an inflammation and swelling of the bursa on the posterior elbow. Some of these people come in with swelling sizes as large as half a grapefruit. Once again, very common. It can result from a direct impact to the elbow or prolonged leaning on the Electron. Differential diagnosis here is that these can be infected, so you can get a septic bursitis. Sometimes it can be an overlying cellulitis that is just in the area of where you would typically get an electron bursitis. You can also get swelling back there with elbow dislocation. Typically, those people will present on field after an acute injury or a ganglion cyst. And there's an association with electron bursitis with a number of other medical conditions, including gout, rheumatoid arthritis, diabetes, alcohol abuse, and HIV infection. On examination, there's a fluctuant swelling, which is well contained at the posterior elbow. It may be warm. Sometimes there's essentially contains a serosagmus fluid, and the elbow range of motion is usually maintained, and it may or may not be tender. In terms of the X-ray imaging, an X-ray, if there was an injury, just to rule out an associated fracture such as an olecranon fracture, and then an aspiration can be sent for culture and sensitivities, as well as a white cell count and polymorph count if infectious is suspected. Just to give you an idea, infected bursitis, typically the leukocyte number is greater than 100,000. However, infections have been seen in as few as 7,000, and then polymorphs greater than 50%. So leukocytes greater than 100,000 and polymorphs greater than 50% would be more specific for an infection of that electron bursa. In terms of management, you want to protect and ice the area, as well as using anti-inflammatories, and consider aspiration. Patients may require repeat aspirations. With respect to cortisone injection, there's been shown to be no improvement in the overall outcomes with cortisone injection, and there is a risk with the cortisone injection. So the aspiration itself may drain clear yellow fluid, or if it's post-traumatic, maybe a serosanguinous fluid. And then if it's infected, obviously considering antibiotic coverage for a prolonged period of time would be ideal. You want some kind of gram-positive coverage, so like a ceftriaxone and clindamycin. And if these persist, they may require surgical excision. I usually recommend you consult orthopedics early on to allow the direction of the treatment of the infected bursitis. Painter's disease, finally, this is osteochondrosis or developmental derangement of the capitellum of the elbow. Typically around age 5 to 12, they present with stiffness and pain. It typically affects boys more than girls. And there's essentially an irregular vascularity of the capitellum that results due to either repetitive microtrauma, valgus stress, or trauma, and it's usually their dominant arm. Differential diagnosis includes radial tunnel syndrome, radiocapitellar osteoarthritis, radial head fracture, osteochondritis dissecans, and referred pain. On examination, they're tender over the capitellum. There's an effusion in the joint. There's usually a loss of extension of the elbow, and there may or not be a loss of supination or pronation. In terms of imaging, the X-ray typically will show an irregular cortical margin, and as well as a demineralization of the capitellum. And then this would be followed by osteosclerosis, followed by a loss of bone volume in that area. In terms of management, in severe cases, consideration of a long arm cast for 3 weeks to reduce pain, and then protection of elbow from loading and demanding activities, followed by elbow range of motion exercises. Posterolateral rotatory instability. So this is an injury to the lateral ligament complex. This is what we were talking about before in terms of where the nomenclature can get a little bit confusing. The radial head and olecranon essentially shift posteriorly from the trochlea, causing clunking, clicking, and sometimes locking for patients. So this is the humerus, this is the radius, this is the ulna, and this is a left arm, okay? So this is the lateral aspect, and medially is the ulna. You can see that this lateral ulnar collateral ligament, like I was talking about before, forms like a sling that goes over the posterior aspect of the radial head, which comes around here, and then attaches onto the ulna, okay? The anterior portion of this lateral collateral ligament complex involves the radiocollateral ligament, which essentially slings over the anterior portion of the radial head, and then there's the annular ligament, which goes around the neck of the radius. The mechanism is usually a prior subluxation or dislocation of the elbow. The differential diagnosis will obviously include a loose body in the elbow, such as an osteochondral defect, osteoarthritis, osteochondritis dissecans, and a radial head fracture. On examination, They have laxity when you put the elbow into varus. They're tender over the lateral elbow, specifically over the lateral ulnar collateral ligament. And then there are a number of other tests. There's a lateral pivot shift test, which you can do with the arm inflection and elbow inflection. And posterior drawer test, which essentially you apply a posterolateral force to the forearm from the volar aspect of the forearm and pushing posterolaterally to see if there's any laxity, and then an apprehension test to see if they are getting apprehensive when you stress that part of the joint. And finally, there's a chair rise test, which you can see in the image down here. So you have the patient supinate, and you try and get them to push up, and they're typically unable to push up on the affected side because it's so unstable, and the joint typically gives out. In terms of imaging, X-ray to rule out any kind of associated fractures, an MRI would be helpful in this situation. There's also talk about using, obviously, from an orthopedic perspective and in hospital, using fluoroscopy to demonstrate the instability. In terms of management, typically recommend conservative initially, so if there's obviously any kind of acute dislocation to reduce, but mobilization, the elbow at 90 degrees for 1 week to kind of promote some stiffness, and then a graduated progression to full range of motion and activities from there. If it persists, then the recommendation would be a surgical referral for a lateral ulnar collateral ligament repair or reconstruction to reduce that instability. Referred pain, so pain at the elbow is not always from the elbow. It can be distributed in a vague and varied way, including neuro symptoms, and not reproducible, typically with isolated elbow movements. The differential diagnosis includes thoracic outlet syndrome, radicular pain, brachial plexus injury, and bone tumors. On examination, typically elbow is non-tender. There is a full range of motion, no fusion. Using clinical judgment, obviously consider examining the cervical spine, and as well as implying and implementing thoracic outlet tests. In terms of imaging, based on clinical suspicion, but based on what you're concerned about, you can consider X-ray, vascular Dopplers for thoracic outlet, and MRI of the cervical spine, or EMG and nerve conduction studies if there are significant neurological symptoms. In terms of managing these patients, depending on the cause, for example, thoracic outlet can respond quite well to physiotherapy. Surgical referral, obviously, if conservative treatment fails and there is a cervical rib, sometimes they'll remove the cervical rib to reduce the amount of thoracic outlet impingement. As for radicular pain, physiotherapy along with neuropathic medications for pain, plus or minus corticosteroids. And if obviously, once again, the radicular pain fails, conservative treatment and consideration for surgical referral could be helpful. In terms of review questions, 5 questions I'd like to ask you are: what are the differentials for snapping in the elbow? Name 3. Name 5 differentials for lateral epicondylitis. The anterior dislocation of the elbow is the most common type of dislocation. What is the long-term complication of ulnar collateral ligament laxity? And what is the commonest fracture of the elbow in children and in adults? Thank you.